Okay, I think it's 2 minutes past, and I think our meeting room is becoming empty. Most people are inside the boardroom, I should say. Welcome everyone again. My name is Lungelo Manyati. Today we have a presentation by Pentax Medical on the best practices of caring and maintenance of endoscopes. Pentax will also share some quick and emergency tips to check and for possible repairs whilst in theater. We all know that endoscopes can be very expensive if not handled or maintained in accordance to manufacturer's standards. So these best practices will be shared by Brandon Oberholster. Brandon has been with Pentax for over 20 years as a service engineer, and he is now a business unit leader for the sub-Saharan Africa. Before working with Pentax, he worked with TechMed, Acacia Medical, and New Medical Endoscopy. On behalf of KISA National Council, welcome Brendan, and thanks for taking time to share your experiences with KISA members. Maybe before I can hand over to you, just a few housekeeping to consider. If we can all maybe keep our microphones off, which I'm appreciative for that, and including videos. We will have a Q&A session after the presentation. So while Brandon is doing his presentation, I would encourage everyone who's got a clarity or question to post their questions on the chat box. Without wasting any time, Brandon, over to you.
Great. Hi, good afternoon, everybody. Hope everyone is well. And again, Ngela and the KISA team, I'd like to thank you for the opportunity to be able to share my experiences and my journey through endoscopy for the past 23 years. So I'm just going to share my screen quickly. Okay, I hope everyone can see my presentation. If we do have a hiccup a little bit through, it's just me shifting over from my load shedding schedule, because I'm due to come off load shedding now at 4:30. So if I do have a bit of a hiccup, please just let me know while I'm going through. Okay, so just a quick topics of discussions which I wanted to go through is a little bit of an introduction for myself to the members that's joined the discussion. And then we're going to have a deep dive into flexible endoscopy, some components and care of the endoscopes, some troubleshooting, what to do in case of an emergency, assessing problems and damages on an endoscope, and what the future holds for endoscopy for all of us as clinical engineers and engineers for endoscopy. So a little introduction from myself. I started my career in the medical industry in the year 2000, where I started off as a Pentax or junior Pentax service technician for pneumatic endoscopy. I worked in Port Elizabeth with a very influential gastroenterologist at the time, Dr. James Garish. He had purchased and invested in quite a lot of equipment, and he insisted in having his own personal flexible technician on site at St. George's Hospital in the Eastern Cape. Once establishing the service in Port Elizabeth, I then relocated back to Cape Town, where I then set up the workshop and the service for the Western Cape, which I'm now currently calling home as well. When I started in the endoscopy market, it was busy in the transition period from fiber optic flexible endoscopes to the first, as it was called, the black and white video processor with an RGB wheel that would translate black and white images to video color images. In 2014, I then moved across from pneumatic endoscopy to Acacia Medical as the National Service Manager. And then in 2018, I moved with the product once again from TechMed, from Acacia Medical to TechMed Limited in 2018. In 2022 is when I took over the role of the business unit leader for Sub-Saharan Africa, and that's working directly with Pentax Europe. It's crazy to see that, flexible endoscopy is now currently at a 4K staging with artificial intelligence. And it's scary to think that 23 years have gone by from looking through an eyepiece fiber optic endoscope to 4K artificial intelligence assisted endoscopy. And then some images on the side here. I just want to open my little laser pointer, showing fiber optic to a very basic endoscopy system and how we've moved across within the years. It's quite a transition from fiber optic scopes to 4K imaging. So before we get into a deep dive into flexible endoscopy, I just wanted to share with you a little video clip from the Homer Simpson getting his first colonoscopy, or his colonoscopy. And I think it also just gives a bit of an overview of endoscopy as well. So I'm going to just start the video.
Homer, I've gotten you the most important gift a man your age can get.
You're having your boobs embiggened? You don't have to. They're fine just the way they'll be.
No, you're getting a colonoscopy.
Oh, that's wonderful. Pardon me for a moment. Colonoscopy is an endoscopic examination of the large... Oh, I don't understand.
They stick a camera up your uh-oh, but this time you won't be doing it to win a bar bet.
That bar bet paid for the camera removal. Welcome to the Mayo Clinic. Mayo. I'm glad you're here, Homer. Early detection can lead to complete removal of tumorous polyps and... Are we going to talk or make a movie? Now, Homer, breathe into this mask. He's asleep. I almost feel guilty about charging for the anesthesia. Almost.
Will he be all right, Doctor?
Listen, don't worry. I've done hundreds of these, and good Lord. This ass is why I became a doctor. This is my Sistine Chapel. This is my Moby Dick. This is my Sergeant Pepper's. How did that get in there?
There's his wedding band. He told me he was getting it polished.
According to this, he has 3 active polyps. Now comes the fun part.
You cut them out?
Oh, we don't use that term. We prefer rip. I feel great. Once there was a mountain, now there's a breeze. Hallelujah. Let's take this new colon out for a spin to Krusty Burger. Oh, Mr. Simpson, the camera's still inside you. I'll return it after Lisa's recital. Hallelujah.
Not a dramatization. This is footage of an actual colonoscopy.
Okay, so I thought that we'd just break the ice a little bit and sort of give a little overview of endoscopy. And I suppose we're all going to eventually get there once upon a time with regards to all being on the table at one stage of our lives. But anyway, moving on. So a deep dive into flexible endoscopy. So flexible endoscopes, obviously, as everyone knows, is an instrument designed for minimal invasive surgery using an open orifice of the human body. So in other words, where there's an opening, we can basically put a flexible endoscope in it. And as you can imagine, endoscopes come in many sizes, from a very small outer diameter, like a ureterenoscope, to look inside the calyxes of the kidneys, to the large outer diameter endoscopes like a colonoscope to investigate and diagnose and treat large colon, as well as covering many medical procedures such as ENT, pulmonology, core GI, and more advanced endoscopies cases such as endoscopic ultrasound, which means for a clinical engineer that these are delicate instruments filled with a lot of technology driven by electricity. And yes, of course, Eskom definitely has a role to play in some faults going forward with some of our endoscopy devices. And the images, if you can see on the side over here, sorry, I just want to get my pointer back up and going. The images on the side, you can basically see that that the different diameters of the endoscope. As you can see, there's a smaller endoscope as well as to a larger colonoscope. Sorry about that. I just switched over now and I received my Eskom electricity. Okay. So moving on, just want to go over the basic parts of an endoscope. So you've got an understanding if I'm discussing a certain point of an endoscope. So if you look at a flexible endoscope, it's comprised of your distal end section. On your distal end section, you'll have your objective lens, your LCD cover lenses, your nozzles, which is going to provide air water through the endoscope, and then your instrument channel outlet, as well as a forward auxiliary jet channel. This is your bending section of the endoscope. Your insertion tube, which is quite explanatory. It obviously gets inserted into the patient. You've got your root brace rubber, a tapered root brace rubber, which is minimal invasive to the patient, because sometimes they do need to utilize this section of the endoscope during a colonoscopy. You've got your biopsy inlet seal, your control body of the endoscope, your air water, your suction valve, your control knobs with your free lever locks. You've got remote control buttons, which you can assign to do different functionalities for the endoscope. Another root brace to your umbilical cord or light guide long cable, which leads to your electrical or your PVE connector. And on your PVE connector, you've got your suction nipple, a grounding port to ground the endoscope while busy doing electrosurgical work. You've got your electrical connector, an air water connector on the other side, and your light guide prong assembly. Okay, so what are endoscopes made of? Endoscopes are an insertion tube and the umbilical tubes. The construct of the insertion of the flexible tubes and the light guide long cable is a polyurethane plastic coating with a metal braiding covering metal coil pipes. So that's basically going to house everything internally. So all your stuffing goes through the insertion tube. So it does have quite a robust outer casing of the endoscope to sort of protect all your components internally, especially your fiber bundles, which are quite fragile. You've got a plastic control body and PVE connectors. You've got metal frames that house all the angulation parts to enable the endoscope to angulate up, down, left, and right. You've got channels within your endoscope, air, water, biopsy, suction, and auxiliary jet channels, and that's all manufactured out of a Teflon. You've got a pulley system that enables your scope to angulate. Some scope manufacturers are made out of chain. Some scope manufacturers are made out of a braid. You've got light guide fiber bundles or LED light to emit the lighting at the distal end of the endoscope. You've got a CCD, which is your charge coupled device, or now the CMOS technology, which is a complementary metal oxide semiconductor chips to transfer of the images to the processing unit. You've got PC boards, as well as CCD and CMOS signal wires running through your endoscope. You've got angle wires, stay coil assemblies, which enable the endoscope to have a tip deflection at the end of the scope. And then you've got plastic body covers, O-rings, bending rubbers, and a lot of screws. So that's basically the composition of an endoscope. I might have missed out a few things, but that is the general overview of an endoscope. So to have a look at, so I've just allocated some images which we're going to just go over and discuss. So this is an insertion flexible tube. As you can see, it is a plastic tube, polyurethane, and you can see there's markings down the endoscope to be able to tell the endoscopist how deep they are inside the patient. This is just an image or exploded image of a PC board and the wirings, because they go from the CCD chip to the PC board. This is an endoscope that's in process of stuffing, and as you can see there, you've got your Teflon channels and all your stuff that is going to be inserted into the insertion tube. And this is what we call a segment stay coil assembly. So as you can see, it's a braided wire. Underneath the braided wire, again, is another coil pipe that houses everything internally, and the distal end seats up in against the segment stay coil assembly. This is an example of a light guide fiber bundle. As you can see, it's an exposed light guide fiber bundle. It normally has a cover sheathing that goes over the fiber bundle. And as you can see how delicate the fiber bundles are. So these fiber bundles, there are 2 fiber bundles that run through an endoscope. And they are very, very fragile. So all the stuffing, as you can see in this distal end image over here. So there's your CCD position there. All your stuffing is positioned inside the insertion tube of the endoscope and is coated with a powder, which is a molycoat or graphite powder. So you can imagine if any fluid contamination occurs to your endoscope, that molycoat powder is going to turn into a bit of a paste. It's going to harden, And these fragile light guide fiber bundles are then going to be compromised and potentially break the next time the endoscope is angulated. So at some stage, if your endoscope has fluid contamination with it, and the fiber bundles do start to become brittle because of the graphite powder, and you'll start obviously seeing a deterioration of the light of the endoscope during the procedure. If you have a look at this image here, this is an image of our distal end. Sorry, it's a little bit dark, but you've got your two lights where your light is emitted through the endoscope. Some endoscopic companies have now brought LEDs out at the tip of the endoscope, and some of them are still running with fiber optics throughout the endoscope. Then you've got your objective lens. It's just a little bit dark, and that is your CCD wire. Behind there, you've got your CCD or CMOS chip, and then you'll have your objective lens. You've got an opening for your instrument channel. You've got an air water channel, and then you would have a forward water jet channel, which is that channel running over there. Okay, just continuing with the components of the endoscope. So this is a control body of an endoscope. As you can see there, there's quite a few components inside here. You've got your CCD signal wire, you've got a grounding wire, you've got a suction channel, air channel, water channel, light guide fiber bundles, and your remote signal wires as well. This is an image of a PVE connector. On your PVE connector, you'll have everything that is basically coming through from your insertion tube coming out to the connector of the endoscope. You've got feather cores to reduce the noise on the imaging. And you have all the tubes, the Teflon tubings that needs to be connected, and that is your PC board that gets connected onto your signal wires. So your remote signal wires and your CCD signal wires will all be connected to a PC board, which is then connected via your electrical sensor, which then sends the image and the signals through to your processing unit. This is a segment stay coil assembly that's in preparation of stuffing. So I'm not sure if it's too clear on your side, but as you can see there, all of those wires that are combined there is basically going into your segment stay coil and into your insertion tube. As you can see, it's quite a tight fit, hence why the need for molykote powder and graphite powder so that everything can rub smoothly against each other. The last image here, we've got a corroded control body of an endoscope. As you can see, this endoscope has encountered a fluid contamination, and you can see the damage that has occurred from the fluid contamination of the endoscope. So those were just a few images and a few items of the endoscope of what we were discussing earlier. So what I want to go over now is just troubleshooting and what to do in case of an emergency. You know, being clinical engineers and engineers, you're going to, at some stage, encounter endoscopy issues. There is certain things you can have a look at on site, and you should be able to resolve on site. And there's going to be instances and situations that you won't be able to assist on site. And unfortunately, the endoscope would need to go away for repairs. So having a look at blurry images, you know, during the procedures, the endoscopist might complain about a blurry image. So your first standpoint to look at would obviously be the objective lens of the endoscope. If you have a look at the objective lens, it might be dirty or possibly damaged. If the lens is dirty, you could either use a lens cleaning solution with a gauze or a web core and clean the dirt off the lens and then recheck the image if it has been cleared up. If the lens is cracked or scratched, it will unfortunately have to go in for repairs, but you would be able to identify that on site. If the endoscope appears to have a misty image, do a leak test, as the instrument of the endoscope may have a leak on it, and there might be moisture trapped behind the lens. Fluid contamination may also be a result of a defective image, which is this image over here. So that's an indication of a fluid contaminated or fluid behind your objective lens. And that's an indication of an electrical fault caused from fluid. And then obviously a cracked or scuffed objective lens. Okay, faulty angulation. That is a common occurrence with flexible endoscopes as well. So sometimes you'll get called into a theater and the doctor will either complain about the endoscope has stopped angulating in a certain direction, or it has potentially become tight or stiff. So obviously, if your angulation has stopped moving in a certain direction, the possible causes is that you've either got a snapped angle wire or the endoscope has pulled the end stoppers off, which will then require the endoscope to go in for a repair at a service center. If the angulation appears to be tight, first thing you would check it is have a look at the free levers locks. So that is a free lever lock. Most endoscopic companies have free lever locks on the endoscope. And sometimes while the endoscopist is performing this procedure, his gastroscopy or colonoscopy, he accidentally tightens the locks. You know, the endoscopists generally know themselves where to look for that. But if you get called in, have a look to see and make sure that the locks are in the free position and the locks are not activated on the endoscope. If the endoscope angulation is still tight and the locks are in the off position, please perform a leakage test on the endoscope, as there might be fluid may have compromised the angulation parts of the endoscope. So if you have a look here, the endoscope over here, this is where all your angulation components are connected together. Through your segment stay coil wires, you have angle wires. And as you can see, all the corrosion and the buildup would definitely hamper the angulation of the endoscope. In this situation, it probably would have made the angulation very tight, to the point that it probably might have snapped. Okay, if the endoscope is not blowing correctly, things that you need to look for is please ensure that the water has sufficient fluid in it and that the water bottle is in the air-water position. Some endoscopy companies have a drain facility on their endoscope. So if the drain facility is in a drain position, you will not be getting fluid or water through your endoscope. You will only be purging air through your endoscope. So please have a look at that. Another thing to look at is your O-rings on the endoscope, and not only the O-rings on the valves, but on the water bottle as well. And the water bottle has about 3 O-rings on the endoscope, on the bottle as well, that you need to look at. And then obviously the valve O-rings. Very important to look at both sets of valves on the air, water, and suction valve, because sometimes the endoscopist will say that the endoscope is not insufflating. During a colonoscopy, it's required to inflate the valve to be able to advance the endoscope. And if you've got a faulty O-ring on the air-water valve, on the suction valve, what happens is the endoscopist insufflates inside the patient, and due to a faulty suction valve, the air that's being insufflated into the patient automatically gets sucked up through the endoscope. And then it doesn't inflate the valve for him to be able to progress the endoscope during the case. So O-rings are quite an important part of checking on the water bottle as well as the valves. Another thing to look at, in this instance over here, you can see there's a crush mark on the insertion tube. So a good thing to do is make sure that there's no visual crush marks on the insertion tubes, because sometimes what will happen is it might depress down on one of the channels of the endoscope, and it being a Teflon channel, it can really push it down and avoid or stop the flow of fluid or air through the endoscope. Okay, resistance when passing an instrument through the biopsy channel. Possibility or things to check it is obviously you're going to have a look if there's no visual blockages at the tip of the endoscope, and as well as by the biopsy inlet where the instrument is passed into the endoscope. Another thing to look at is make sure that the insertion tube has not been compressed or damaged in any way, which might have then internally caused damage to the biopsy channel. Another way to check it is if you lay the instrument or the endoscope in a straight position and then pass an instrument through. If you feel any resistance at a specific spot of the channel, it is 9 times out of 10 you've created a kink, or there's a kink in the instrument or damage to the instrument, as you can see in this image over here. This image on the right over here, maybe your left, is a damaged insertion tube, which has obviously impacted the instrument channel as well. Okay. If an endoscope fails a leakage test, at any stage, please request either the cleaning or the CSSD staff not to proceed with a complete reprocessing cycle of the endoscope, as fluid contamination is the largest contributor to major failures of any endoscope, escalating a repair to potentially blowing a CCD or CMOS chip of the endoscope. So 9 times out of 10, the damage is going to occur during a procedure. While the endoscopist is utilizing the instrument, perforation of the instrument channel or a needle passing through and damaging a channel is very possible. But what happens is the leak goes undetected, and the cleaning and reprocessing sisters, they continue with the reprocessing of the endoscope, which then in turn causes fluid inside an electronic device, which does not go well together. So sometimes a small, simple repair like this over here, which is just an instrument channel replacement, going undetected, turns into severe fluid contamination and possible PC board and CCD damage because it wasn't detected before they started the reprocessing of the scope. If at any stage they do find that the endoscope has got a leak on it, they are to wipe the endoscope off as best as possible, place the endoscope in a red contaminated bag, and contact the supply company for a repair. You know, a little example I like to give the CSSD and nurses is, you know, the endoscopes have got a bending rubber on the distal end over here, or the bending section of the endoscope. And it's a piece of rubber. Patients come in for a gastroscopy. They have, some patients don't have bad back teeth, or they got a chipped molar. A bite block prevents the patient from biting down on the endoscope, but doesn't prevent broken teeth. And if the patient struggles during the intubation period of the endoscope and it nicks the bending rubber and perforates any stage of this part of the bending rubber, your CCD and CMOS chip is positioned right there at the distal end of the endoscope. And if it goes undetected, a leakage test doesn't get completed. The endoscope goes through a reprocessing cycle, and you fluid contaminate your endoscope. A simple bending rubber, which would be covered in a normal Class A service of, call it 1,500 Rand, has now escalated to a blown CCD or CMOS chip, which runs into the 70s to 100,000 Rand repair. So something as small as a broken molar tooth of a patient could inflict damage to the bending rubber, which could be a very quick and easy repair, but because it goes undetected, actually ends up costing a lot more in the long run. Okay, so assessing problems with damaged or faulty endoscopes. So what we're going to go over here is I'm going to just show you a series of images that you might encounter or you might come across during your inspections of the endoscopes, you know, to help you and guide you in the way that you need to assess it. So if you have a look at the first image over here, this is a video image that has become faulty. So it could, 9 times out of 10, a faulty image like that has occurred because of fluid contamination to the endoscope, which could then have a faulty drive PC board or a faulty CCD chip or CMOS chip. The next image over here, again, sorry it's so dark, but these are the 2 light guides over here. If you can see, only the one light guide is illuminated and that light guide is not illuminated. So the way to check it is, obviously, if you have the endoscope connected to the processor and you switch it on and only one light is burning, you know you have a dead light guide fiber bundle. So if at any stage the endoscopist or the physician working with the equipment is complaining that the image is dark or it's casting a shadow, the first thing to look at is obviously your light emission out of the tip of the endoscope. Because what happens during a colonoscopy, a colon is full of folds. So if the good light goes up against the fold of the colon and the bad light or the light guide that has not got any light is meant to be shining out and it doesn't, it casts a very bad shadow, and sometimes to the extent that they cannot see. During a gastroscopy, when the doctor or the physician does a retroflex maneuver to look back up at the opening of the stomach, due to the fact that there's only one light and they're so far away from the visualization, the image looks completely dark. So if at any stage you get a doctor or an endoscopist that is stating that the image is dark, have a look at the light guides. For snapped angulation or pulleys, as you can have a look over there, this is a braided pulley wire, which has now become faulty and snapped. Those are the pulley lugs that connect them together. You've got an angle wire, which then runs inside a coil pipe or a stay coil wire, which is attached to your segment at the end. So at any stage during a procedure, if the endoscopist hears a pop or clicking sound and he cannot deflect the endoscope in one direction, generally the fault would be a faulty or snapped pulley, or sometimes the angle wire also breaks as well. Okay, if at any stage the endoscopist is complaining of a tight segment stay core, or the tip deflection or the tip angulation of the endoscope is feeling tight, please have a look at the externals of the endoscope. Make sure that there's no crush marks or damage marks to it. If there is, that could definitely hamper the angulation of the endoscope. And again, as well as the air, water, and instrument channels may become damaged as well from that type of a damage to the endoscope. If at any stage you see an image as such, where you're getting spots on your image, spots on the image could be a possibility of fluid contamination of the distal end, or possibly the distal tip of the endoscope has been dropped and has caused a bit of shattered glass or some contamination of moly-coated powder against the objective lens. Again, if you're having a blurry image, this is also a good thing to look at, to have a look to make sure you do not have any dirt. Sometimes after the endoscope has been reprocessed, they will hang the endoscope up. Once the endoscope is hanging up, the nozzles might still have some form of a fluid or even contamination to it that will be dripping out over the lens. And the next day, or it sits overnight, and the next day they want to start the cases or the procedures, and they're complaining of a blurry image or a light that's not being emitted correctly. Have a look to make sure that the distal end is nice and clear. Sometimes with usage of chemicals, you come across the drying of either the insertion tube or the light guide section of the endoscope, where you see cracked or perforated marks on your insertion tube or in the polyurethane. That in turn will then cause the endoscope to leak, which will then in turn, if undetected, go across into major fluid contamination and potentially an endoscope looking like that. Again, an endoscope like that has definitely got hampered angulation, as well as the potential of getting stuck inside the patient, because what potentially could happen is the angle wires could become seized and the endoscopist angulates the scope, but the scope cannot become unangulated again. And that is all caused from severe corrosion of the endoscope. So just ending off the topic of fault and problem finding with endoscopy. So please, if you're unsure of whether your endoscope needs some sort of a form of repair or service, to please contact the suppliers of the equipment, as most endoscopes now carry a 24-month warranty period of the instruments, and it's advised to send the equipment to an accredited certified center that solely repairs your brand of equipment. Okay, so moving on to the future of endoscopy. So future of endoscopy, there's a lot happening now, you know. Like I was discussing earlier, we've gone from doing fiber optic endoscopes. I was fortunate enough to be trained on fiber optic endoscopes. And, you know, to see that we're currently sitting at like 4K ultra high definition processes, CMOS technology that is busy taking over the CCD, 4K, 12G monitors, smart devices being incorporated like a cell phone smart technology into endoscopy processing unit, 5 LED lightings, so no more costly xenon lamp replacements. Artificial intelligence in colonoscopy for polyp detection and characterization. Red density. So red density is an ulcerative colitis scoring for IBD patients. So it's for the detection of ulcerative colitis, and then potentially scoring the IBD patients as well. And then single-use endoscopy. So single-use endoscopy has now grown from your smaller diameter endoscopes like pulmonology, and now starting to gather a lot of traction in the GI as well. There's currently single-use duodenoscopes out in the market, and I know that China is very active with their gastroenterology equipment and pushing it quite hard. You know, obviously being in Africa and in South Africa, we're still quite a far way away from single-use endoscopy, but it's a reality. It's moving into our division. It's already starting to pop up in GI, and yeah, it's quite a scary thought to think that, you know, we could potentially be moving into a market where a patient will walk in with their own endoscope. I'm sure as clinical engineers, it would be a blessing in disguise, so we don't have to worry about damaged endoscopes. So once they use it, they just trash it. But just to let you know as well, from a sustainability point of view, that Pentax has obviously adopted quite a strong standpoint against sustainability of using single-use and plastic products. So yeah, it's definitely something which we have to be concerned and care about. So just to chat about CCD versus CMOS, I don't know if anyone's had a look at the OmniVision white paper on the future of endoscopy. This is just a little cutout from it. So yeah, obviously with CCD, you've got limitations with endoscopic imaging. You've got the size of the CCD. CMOS chip technology is obviously a lot smaller. You can get smaller chips than what you can get in CCD. So you've got 4K imaging on CCD, but the CMOS chips are smaller. CMOS is safer, CMOS is cooler, CMOS is more advanced, and CMOS is better. So it's a good read. I found it very fascinating to go over this little white paper. This is just one page that I took out of it, but it's quite scary to see. You know, CCD has always been a performer and always been, you know, the stable competitor for imaging in endoscopy. And CMOS never really had much of a showing until about 2015. It started poking its head in. And as you can see, it's really on an upward trend. So CMOS technology is definitely, you know, the way endoscopy markets are starting to go and look at. And as well as it's a cheaper repair as well. A CMOS chip is a cheaper repair than what a CCD is. From what our intelligence on CCD versus CMOS is that CMOS is definitely going to be taking over, and they do see CCDs actually becoming obsolete at some stage. So I'm just going to show you a few videos quickly. They're not very long, just a little bit about the 4K imaging with the zoom function. There's no sound to these videos, so I'll just show you or discuss with you what is going on there. So this is an image using a zoom in endoscope. And as you can see, the blood vessels in the mucosa tissue of the patient over here, and how the blood vessels are being fed with blood. You know, it's quite fascinating, like I said, to see how we've gone from fiber optic images all the way to, you know, zoom functions that you can actually see blood being flown through a vessel submucosally of a patient. I really find it quite fascinating. And obviously with the advancement of the technology, you know, the detection and the characterization of different diseases obviously becomes a lot better for the endoscopist. So this is also, again, iScan technology as well, using 4K imaging for the reflux disease. So again, this is endoscope used with a cap-assisted endoscopy, so hence why there's the white ring around it. But this is just using a eye scan or form of technology where they use software to manipulate the color contrasts of the image to detect the erosions of the esophageal reflux into the esophagus of the patient. As you can see over there, there's a distinctive differentiation between the tissue patterns or the two tissues of the mucosal wall, which is a clear indicator for the endoscopist that the patient is suffering with a reflux disease. Okay, and then polyp detection using artificial intelligence. This is my last little topic. So artificial intelligence is definitely making its way into endoscopy. Artificial intelligence has been out for a while for flexible endoscopy. We're currently utilizing it for the detection of polyps during a colonoscopy, and there has been proof and papers written on that it has got a benefit using artificial or AI for polyp detection. There's manufacturers out in the market, in the endoscopy market, that has taken it one step further, where they're not only utilizing it as a detection, but for characterizing as well. So they could characterize a specific polyp as well. So this has got a little bit of a sound to it. It makes a little peep sound, but it's just indicating or just showing you the images where a potential polyp could be, which would need to be investigated by the endoscopist. As you can see, it puts a little blue box around it, and it will make a little mark or a little ticking sound to indicate to the endoscopist, and there definitely is a place for it in the market. AI is definitely coming into the medical industry quite fast and furiously, and I think if we don't embrace it and move with it, we could potentially be left behind. And that is me. Thank you very much for listening. And I think, Lungelo, if we're going to be opening up for a Q&A.
Yes, Brendan, thanks very much for your presentation and also resting our fears a little bit with regards to scopes. It's a very intimidating piece of equipment to consider, because each time when you get a call or maybe a requisition to go and have a look at it, the only one thing that comes to mind: wrap it up and send it to the sole provider to actually repair. But I think your explanation with regards to components that makes it up, I think it helps a lot, and it gives one some confidence also to look at few tricks and tips also while you're still in theater, to try and minimize the downtime and also assist the clinicians with their task of ensuring that patients are being attended to timelessly. So thank you very much for that.
My pleasure.
I've requested some questions maybe to be posted on the chat box. I don't know if maybe you've overwhelmed us with some information, but I don't see much being posted. But to our members, this presentation, I think Brendan has been kind enough to us to allow us to actually post it on our communication platforms. So please keep an eye on that. Dita, who's our admin office, will be posting this in very soon, and you can always maybe make a reference to it, and also keep it in mind if ever you have a similar product in your institution or environment that this information might come useful. One thing I wanted maybe just to ask you, Brendan, maybe while we allowing someone to type, is you spoke about those single-use disposable scopes. Those are very intimidating, but I just wanted your honest opinion in terms of its cost effectiveness. I know you mentioned a few about sustainability, but what's your honest view about it?
Lungelo, obviously, it's discipline specific. So when we look at bronchoscopy, for instance, or pulmonology, I feel there definitely is a market for it. You get a lot of strains of tuberculosis, drug-resistant tuberculosis. It's a very infectious part of the body that the endoscope is going into. So for that instance, I do feel there is a market for it. Single-use endoscopy for pulmonology or for bronchoscopy, I think should become quite a common occurrence for our market, especially your tuberculosis hospitals that specifically diagnose and treat patients with a specific disease. So when it comes to bronchoscopy, I do think there is a market for it. And I think that we should definitely start looking at it. Even if you look at the costs of a repair of a video bronchoscope versus the cost of a single-use bronchoscope. At the moment, I think the single-use bronchoscopes come in at about 5,000 Rand or just a little over 5,000 Rand per endoscope. So sometimes you've got to weigh up the pros and cons. Is my hospital spending more money in repairs per annum than what I could actually do single-use endoscopes? So if it's a high turning unit that's, goes through a lot of repairs on the endoscope, maybe it's a feasible thing to look at. But when you look at gastroenterology, like your upper GI and your lower colonoscopies, I think there we're still very far away from it. It's not a sterile procedure. It's obviously an infectious procedure. You can cross-contaminate, but the risks is a lot lower than, for instance, a bronchoscope. So when you're talking about core GI, I think we're still quite away from single-use endoscopes. And it is a scary thought, especially for the environment, to think how much waste there is potentially. I think for a normal endoscopy procedure, the last numbers I saw was that from one GI procedure, colonoscopy, you could use up to about 13 kilograms of wastage that needs to be incinerated. Now you're including a scope into that as well. It could, be bad for the environment.
Yeah. No, 100%. I agree with you. I must admit also that when I received a proposal for actually a disposable one, it took long for me to actually give it a thought, because I was weighing the actual cost of the unit and the innovation that is in front of me, and it was too much to actually digest. But as you say, perhaps it's something that one needs to really think about and also do some research going forward with regards to. Yeah. Okay, I'm looking at the chat boxes here. Quite a few comments, positive comments with regards to the presentation, Brendan. But I'm just going to quickly go to Winston Padaki's one. He said, having different flexible scope brands in our institution, user training for reprocessing is important to reduce major damage, especially the leak test stage. Is there a standard reprocessing procedure for end users, or does it differ from manufacturer to manufacturer?
So the general consensus of way you reprocess an endoscope is pretty much the same. When it comes to leakage testing your endoscope, some endoscopes might have a different protocol. For instance, Olympus has a connector that connects to their light source, and they do a wet leakage test. The Pentax brand, we do a dry leakage test of the endoscope, which is outside of fluid. So when it comes to leakage testing, it is brand specific. But a nice thing about it is we're moving so much into a digital world, and being able to do so much training online. For instance, with us at Pentax Medical, we've got a site called Pentax Medical, My Pentax Portal, where you can actually go through step by step on a training course, where you can go and you can see how to do a proper reprocessing if you're doing a manual reprocessing versus an automated reprocessing and leakage testing. So a lot of times, you're head of a unit, for instance, a gastroenterology unit, and you've got a specific brand or product in there, get the team in, get the sales guys in there to give them upscaling training, and then potentially put them onto a digital platform. Because, you know, sometimes they switch staff very often. You'll have a sister in today cleaning an endoscope, and tomorrow it's a different sister. Whereas if they have access to a smart device like a phone, you have access to a digital platform which you can teach very quickly how to do a reprocess of an endoscope.
No, 100%. The one thing maybe to add and also to share as an experience on this, Brendan, is it's always worthwhile also to now and then pop into theater or that washing area, just to go there and see how the end users are actually doing the washing, not with the intention of actually exposing or catching them up, but I think just on the polite manner to monitor also on the practices that they are actually being taught on, and to see if that is actually bearing fruits, because I think that confidence also goes a long way in terms of ensuring the sustainability and also the lifespan of that product into that area. So maybe something
definitely
worthwhile to consider.
Yeah.
Okay. I don't see any other question. I think thanks again, Brendan, for your time and also for your experiences. We can see that the 20 years really has been invested somewhere, and it's bearing fruit. We appreciate that a lot. I think, yeah, without any further questions and comments, I would like to close this session and encourage everyone to keep an eye on our communication platforms for our next webinars, which will be posted. And as I said again, for the members that joined later, we will be posting this presentation on our communication link. Feel free to make reference to it. But yeah, thank you very much, everyone, and good afternoon.
Okay. Thanks. Bye-bye.